Hi, my name's Rosie Slater. I'm a speech and language therapist from the United Kingdom, and I have been working in the Cleft Hospital in Gujarat. The Cleft Hospital in Gujarat specialises in providing a multidisciplinary team approach to the management of cleft lip and palate. And in this short session, I want to talk to you about cleft palate speech, how we assess it, how we go about that. You will know that priority is that a child will have their cleft palate repaired at the optimum time. But we know that even at repair at the best time, at least 20% of children will continue to experience escape of air through the nose, resulting in nasal speech, even after they've had their palate repaired early. We also know that 40% of children with a repaired cleft palate will continue to have speech difficulties, and it's very important that we are involved as speech and language therapists. Why do we need to be involved? Well, the impact of having a speech and communication difficulty is quite significant. We know that children who sound different may be perceived more negatively. We know that escape of air during speech is very intrusive in conversation. And we know that unclear speech can be associated with limitations in peer relationships, social skills, reading and writing. So what are the speech features that are associated with cleft palate? The areas that we need to consider are resonance, nasal airflow, facial grimace, and speech sound errors. Speech and language therapists are always concerned about velopharyngeal function. Velopharyngeal function describes the palate to pharyngeal closure mechanism that operates in speech and swallowing, and when that mechanism is deficient or inadequate, there is dysfunction. In terms of resonance, what does the velopharynx have to do? What is the normal velopharyngeal function for speech? Well, we know that the soft palate needs to elevate, that the posterior pharyngeal wall needs to move anteriorly, and the lateral pharyngeal walls need to move in. We know that we all have different velopharyngeal closure patterns, and we know as well that it does vary with different speech sounds, with the greatest velopharyngeal closure needed for high pressure consonants. Resonance. What is resonance? Well, resonance is the balance of air in the oral and nasal cavities during speech. Hypernasal resonance is a perceptual feature of velopharyngeal dysfunction, and it's very important that as speech and language therapists we listen to the child or young person talking and we evaluate their resonance. Is it normal? Is it hypernasal? It's very important that we do that evaluation. We also need to evaluate for nasal airflow. When velopharyngeal closure is incomplete, air can pass through the nasal cavity, and that is perceived as nasal emission and/or nasal turbulence that can accompany oral consonants. It's very strongly associated with velopharyngeal dysfunction, and it can be audible or inaudible. So as part of our assessment, we need to be assessing and evaluating if there is nasal airflow present. Nasal turbulence is part of nasal airflow, but it is noisy nasal airflow accompanying plosives and fricatives. Nasal turbulence is most usually associated with a small velopharyngeal gap, but it can be very distracting to listeners. So it's very important that we are listening and evaluating for nasal turbulence as part of our evaluation of airflow. Nasal or facial grimace is a compensatory behaviour by the speaker that occurs subconsciously. The speaker will constrict their nostrils or their facial muscles in an attempt to inhibit abnormal airflow through the nose. And again, this can be an indicator of velopharyngeal dysfunction. There are different degrees of grimace. It's important that we look for that and we notice it and report it if it is present. And then speech sound production. Velopharyngeal dysfunction can result in insufficient intraoral air pressure to produce oral consonants. In its most severe form, the oral sounds are produced as their nasal counterpart. So a b might be said as a m, a d as a N. There can also be very weak oral productions. Sometimes children can have developed compensatory articulations to compensate for the VPD. Compensatory articulations are those articulations that are produced non-orally. So for example, glottal plosives, pharyngeal plosives, pharyngeal fricatives, nasal fricatives, those sounds that are produced outside of the oral tract and outside of the typical speech sound system for that language. It's very important that we are evaluating speech, we are listening and transcribing what the child is saying and monitoring and evaluating the type of articulation and the substitutions that they are using. Not all speech errors are associated with cleft palate will be as a result of velopharyngeal dysfunction. And it's important that as part of our assessment and evaluation, we are deciding those speech errors that may respond to therapy and are unlikely to be affected by surgery, and speech errors that may not respond to therapy until surgery has facilitated structural change. What are some of the speech errors that we will not want to treat? Well, things that are not appropriate targets for therapy are hypernasality and or nasal emission that is caused by structural insufficiency. So we don't get distracted by trying to do blowing exercises, sucking exercises in the hope that that will change the resonance. If there is velopharyngeal dysfunction, then that is a structural insufficiency that will need to be corrected by surgery. We also don't try and treat nasal emission that is caused by a fistula. If our assessment has shown that the air is coming down through the nose because of a fistula in the oral area, then we need to refer that child back to the surgeon for consideration of further surgery. And we also don't try to treat misarticulations that are caused or result from oral structural abnormalities such as a class 2 or a class 3 malocclusion. So that's a summary of the areas that we need to assess whenever we are working with cleft palate children. So we need to look at the speech features that are associated with cleft palate: resonance, nasal airflow, facial grimace, and the speech sound errors.